Well, good afternoon, everybody. My name is Dr. Howard Shaps. I am the Medical Director for Healthcare Excel, and we're going to be talking today about adverse drug events. So we're going to start with some quick definitions, and primarily, for the first thing we're going to talk about is what is an adverse drug event. And the key word when you're talking about ADEs or adverse drug events is that an ADE is an injury, which results from medical interventions related to a drug whose outcome is unexpected and unacceptable to the patient and healthcare provider. So everything we talk about the rest of the day, rest of the talk, is going to be talking about specifically injuries and how they occur and why they occur and what we can do to stop these injuries from occurring. And some background information as we go on is that adverse drug events secondary to medication therapy are the most common type of healthcare-associated adverse event we see today. And you can have medication errors, but not all medication errors result in adverse drug events. We're going to discuss medication errors momentarily. So what are medication errors? They are a preventable event that may cause or lead to patient harm while the medication is in control of the healthcare professional, patient, or consumer. It's a mishap, and it doesn't always lead to an injury. Some other definitions. Potential adverse drug event is exactly what it sounds like. It's medication error that are stopped before harm can occur. And then adverse drug reaction or side effect is harm that's caused by a drug at a normal dose during normal use. And I'm going to show you a graphic which incorporates all of what I've just talked about into a picture that sums everything up. So medical errors incorporate almost all of what we see here, and you can have a potential adverse drug event from a medication error that doesn't cause any harm. You can have an adverse drug reaction, which again is a side effect, or you can have injury or an adverse drug event. Here's a good example as to how we can have a medication error, which may lead to a potential adverse drug event or an adverse drug event or an ADE. So here's some examples of harm that occur to patients from medicines. A rash, and some rashes actually can be fatal. Changes in respiratory rate or heart rate, which can cause significant harm. Mental status changes, seizures, diarrhea, anaphylaxis, and fevers are just some brief examples of harm that's caused by drugs. And medication errors are listed on the left side of the screen occur very commonly. It could be a missed dose, an illegible order, a duplicate therapy, and the list goes down. And as we see on the other side of the screen, medication errors result in adverse drug events about 1% of the time, and remaining 99% are potential adverse drug events. So, and then one more stat to give you is that medication errors, about 25% of adverse drug events are secondary to medication errors. And here's a graphic that shows medication errors that cause adverse drug events. And again, these are dosing errors, allergies, the wrong drug, the wrong patient receiving the wrong medicine, a route error or frequency error. And these all are medical errors that can lead to adverse drug events. So we're going to give you some statistics now, which some of them are quite shocking. More than 4 million visits to emergency departments, doctors' offices, or other clinics are due to adverse drug events every year. And there's almost 10 adverse drug events per month for every 100 residents of long-term care centers. And ADEs can increase length of stay in the hospital anywhere from 1.2 to 2.2 days, 1.7 to 2.2 days. Some more statistics. Adverse drug events significantly will increase hospital costs anywhere from about $2,000 to $3,000 per event. And then mortality rates for those who experience adverse drug events are significantly higher for those that don't experience an adverse drug event, somewhere between 3.5 to 1.1% or so. The next stat comes from a journal published in 2000, and I'm not sure how accurate it is today, but nonetheless, this article stated that 9.7% of adverse drug events cause permanent disability. And then, according to AHRQ, somewhere between 1.5 and $5.5 billion a year can be attributed to adverse drug events, which is all pretty shocking. So, adverse drug events, they cannot be predicted by patient characteristics or type of drug used, but we'll see that a disproportionate share occur in those that are over age 65. And those that are in the ICU, that sustain an adverse drug event are more likely to have a life-threatening problem than those that are not in the ICU. So, although age, severity of illness, intensity of treatment, and polypharmacy have all been associated with adverse drug events, no cause and effect relationship is known to exist between patients who suffer ADEs and age, comorbidity, or number of drugs received. And I'm going to list some medications in the next two slides that are commonly associated with adverse drug events. The exact type is not always a predictor, although some certain medications tend to occur more often to cause harm. So antibiotics, analgesics, cardiovascular drugs, sometimes the anticoagulants and cancer drugs can cause some harm. Another list here are the GI meds, antipsychotics, diuretics, antiemetics. They can all cause significant harm to patients who receive these medicines. So where we're going to go now is we're going to talk a little bit about how adverse drug events can be prevented, can be detected. And there's been some research done by AHRQ, and they've shown that computerized systems can reduce medication errors and prevent adverse drug events. And their studies have shown that anywhere between 28 and 95% of adverse drug events can be prevented. Then two studies attribute somewhere between 40 and 60% of ADEs to excessive drug usage for the patient's age, weight, underlying condition, and renal function. However, there are systems in place that can prompt clinicians when these medicines are being considered, and they're not always being used. Here's another good example. Hospitals typically rely on hospital staff to complete manual written incident reports. However, very few percent of adverse drug events are reported this way. And if automated systems were involved, this number would definitely be a lot higher. So we're going to go talk about computerized physician order entry. And there was a study done at Brigham and Women's Hospital in Boston. And their study showed that computerized medication order entry can reduce can reduce an adverse drug event up to 84% of the time. It will eliminate illegible orders, and when you use computerized physician order entry, the name of the medicine, dosage, the route, and the frequency all need to be entered. And if any of these are missing, it gives you a prompt. It gave you a prompt that something needs to be changed. So computerized physician order entry is becoming more and more popular, and it's going to help hopefully prevent ADEs or medication errors from occurring in the future. So there are algorithms that check dosing frequency. They can tell you about medication interactions that the patients are taking, any kind of allergies. It will prompt you about consequences of therapy, benefits, any risks or contraindications. So all of this is built into these computerized systems, and we're going to talk about electronic health records in a little while. However, this computerized physician order entry is key to helping prevent as well as detect potential errors as well as ADEs that occur. So we're going to go through a list of several ways to prevent adverse drug events from occurring. And the first one we're going to talk about in a moment will be medication reconciliation, and the other ones are listed on the slide below, but they're electronic health records, compliance tracking for your patients, patient education, and a pharmacist assistance can all help prevent ADEs from occurring. So exactly what is a medication reconciliation? Well, it's the process of avoiding such inadvertent inconsistencies across transitions of care, meaning patients go from a nursing home to a inpatient facility, back to a nursing home or to a long-term care center, and there are certain transitions that occur where medicines sometimes don't get transferred properly. And the medication reconciliation form is there to help these medicines go with the patient from one place to the next and keep their medicines in line. So the reason it's helpful is because patients, when they arrive at a hospital or arrive at a long-term care facility or a nursing home, they often receive new medications. They have changes to their medications. Sometimes the clinicians in the hospitals do not have access to all the medications that they take on a daily basis, or may be unaware of recent changes. So what happens is without this form, with the medication reconciliation, sometimes medicines are left out, duplicate medicines are written, and even incorrect doses are sometimes seen. So again, these are some of the areas where we typically encounter transitions and where the medication reconciliation form comes into play. Transfers within a hospital, outside the hospital, as well as when people get transferred into a hospital as well. The medication reconciliation literature has shown us that there's unintended medication discrepancies that occur in these transitions. And 33% of the time it happens at admission. It can happen 33% of the time at transfer from one set of care within a hospital. And 14% of patients at hospital discharge sometimes will have discrepancy in their medications. So the medication reconciliation form will help tremendously, hopefully prevent these errors from occurring. So at a Wisconsin-based hospital, they looked at a study before and after implementing the medication reconciliation forms, and they found that they had 213 errors per 100 admissions, and after implementation, it was significantly improved, down to 63 per 100 admissions. And they did this medication reconciliation process upon admission to the hospital, transfer within a hospital, as well as discharge to home or to the next facility to where they were going. There are some common themes that are present throughout the medical literature. We've seen that medication histories are inaccurate, they're incomplete, and sometimes when they are used to generate future medication lists, it can cause problems down the road for the patients. So incorporating medication reconciliation process at all transition points of care will definitely help reduce medication errors, reduce the potential for patient harm, and with the use of computerized physician order entry, hopefully the medication reconciliation form will allow better patient care as well as less errors as well as events occur in the future. And finally, as we've touched on, the computerized physician order entry it's important, but the accuracy of information that gets imported into the system is also very important. And these records will follow the patient from office to hospital, back to office, or to nursing facility as well. And when these medicines reconciliation forms are validated and verified, hopefully events in the future will be prevented. So here's a little graphic that shows you about errors that can occur when there's not proper medication reconciliation forms in effect. And if they're not done properly, 6% of patients can actually have severe harm incurred. So the recommendations for the medication reconciliation form is that pharmacists need to be involved within the clinical team. We're going to talk about pharmacists' roles in a little while, but with the pharmacists getting involved, hospitals need to have a formal process to ensure that these lists are being produced, and they're being used properly. There needs to be some compliance tracking, and when they get transferred out of a facility, nursing facilities need to work in tandem with the hospitals. Now, as the implementation of electronic medical records become more and more routine, these medication reconciliation is going to be incorporated in there as well, and hopefully this will prevent adverse drug events and errors from occurring in the future. So as we transition into electronic health records, we touched on it a little bit earlier, but computerized physician order entry gives you the ability to track patients' diagnoses, their allergies, their height, their weight, and their vital signs, which is key because, as we'll see, when medicines are ordered, the proper medicine and proper dosage can be ordered this way. The EHRs can have formulary information in there and automatically do a utilization review for drug interactions as well as utilization review for use in general. As we go on about electronic health records, it allows for automatic routing. So a prescription can go straight to a pharmacist for processing instead of using a handwritten prescription that has to be dropped off. Medicines can be renewed automatically. It can be used for quality reporting indicators, and more with mobile technology becoming more and more vital to providers' ability to take care of patients. It's going to help from a web-based and mobile standpoint to help with the EHRs to make sure the medicines that are given to the patients are correct and ordered properly. We talked about the wireless operation, which is going to be key, I believe, in the future. A lot of these CPOEs have intuitive interfaces, which make it very easy for the physician as well as the nurse to be able to use. And with the electronic health records, it's going to be much easier to integrate with the facility's financial system, pharmacies, as well as for the use of pharmacy benefit administrators. And here's a study that was done by Valley View Nursing Center, Nursing and Rehabilitation Center in New York. And they noticed that they had an adverse drug event reaction baseline, adverse drug event occurrence of 2.81 times per month, and the clinicians spent over 1,000 hours per week processing orders, not clinicians, but the hospital staff. And their goal was to decrease adverse drug events and time spent on order processing, and they implemented a physician order entry system via their computer system. And believe it or not, after the study was done, they decreased their adverse drug event rate from 2.81 per month down to 0.4 per month, which was an 84% reduction. And time that was spent on processing orders decreased tremendously from over 1,000 hours down to 370 hours per week, a 66% reduction. And this absolutely decreased the amount of errors as well as the decreased costs as well. And it proved to be a very, very beneficial project they implemented. And here's a study that was done in Massachusetts back in 2009, and it was done by clinicians looking at a commercial electronic prescribing system that was in place in Massachusetts for about 2,300 clinicians that wrote almost 208,000 prescriptions. And they noticed that when they went back and looked at their data, with this e-prescribing system, they think they prevented about 400 adverse drug events. They prevented 3 deaths, and they think that they prevented 39 fewer hospitalizations, 34 fewer emergency department visits. An alert would go off when the physicians prescribed medicine, and it caused a significant reduction in adverse drug events and possible morbidity and mortality. And they saved a good amount of money as well. It saved over $400,000 during this 6-month period. Next, we're going to talk about compliance tracking. And compliance tracking, we know is high when the patient's in the hospital. We know that the patient's medicines can be monitored, and there's checks and balances in place to make sure that the patients actually receive the medicines that's ordered for them. However, once you leave the hospital, we often notice that the compliance for patients lags, and how well they take their medicines, and whether they take their medicines on time, if they miss a dose. So there are resources available for patients as well as the clinicians to increase medication compliance. And there are internet resources available. There are personal reminder products such as pill boxes that are available, written logs, alarms. More and more mobile applications are being used. And then electronic health records for practitioners are being used as well to alert a doctor or a pharmacist or a nurse practitioner, physician's assistant when a medicine needs to be renewed for the patient. When talking about compliance tracking, it's important to make sure that the patient understands the importance of taking their medicines. So health literacy is the key topic. Often hospitals will do telephone follow-ups with patients to ensure that they're taking their medicines properly. And health coaches are being used more and more these days, such as social workers and nurses, to help the patients understand taking their medicines are vitally important. And the pharmacists can get involved as well. They can be in contact with patients after discharge. They can monitor whether or not patients are refilling their medicines and taking their medicines as they should be. And they can also verify that the patient has access to the medicine as well as they have the ability to pay for the medicine, because often we'll see patients will drop off a prescription and they won't have the ability to pay for the prescription when they want to come pick it up. So the pharmacists can get involved in this regard as well. Patient education tools are very important, and when we suspect that a patient may have low health literacy, these tools will help patients distinguish between medicines. They'll better understand dosing and timing. Hopefully they'll be able to understand the side effects that could occur, they understand their labels. And so low health literacy affects all of these, but by increasing their health literacy, hopefully these errors will not occur. When talking about education tools and provider challenges, we all know that there are time constraints when talking to patients about their medicines, and medical jargon is often used. So it's important to set aside some time to make sure the patients know which medicines they should be taking, how they should be taking them, and the less use of medical terminology, the better off the patient's going to be. And the providers need to understand that patients often have multiple sources for medications, maybe taking multiple medications from these multiple providers that we just talked about. So here are some specific educational techniques that we can use with our patients. Again, plain language is very important. Anything that is written and given to a patient should be written at a 6th grade level or lower. Key messages or key medicines and their uses need to be repeated and repeated. Often teach back or show me is important, so that the patient can show you how to take the medicines properly. They can teach you how to use the medicine. If they can do that, then most likely they'll be taking their medicines properly. And then encourage patients to ask questions, as well as giving them friendly materials to use once they leave the clinic or the hospital, the office setting, to ensure that they're taking their medicines like they're supposed to be. So one other process will help with decreased adverse drug events is when a patient enters a clinical arena. Their medicine should be reviewed in the beginning as well as the end of each visit. Written instructions need to be clear. If pictures are used, they should be appropriate. Demonstrations may be in order. And then it'll always be wise to discuss non-prescription medications with your patients to make sure that they understand what they're taking and why they're taking it. And when you review the medicines of the patients, here are some simple questions you can ask your patients to make sure they understand what they're doing, how they're doing it, and how they're taking it. So ask the patients if they can name their medicines, if they know why they're using them. Ask them if they think they need them, and if not, why. Ask them if they forget to take the patients. And again, there's a series of questions you can review with your patients just to make sure they understand the exact use of all their medicines and understand why they're taking them. So as we go on, more and more these days, teamwork is becoming very, very important, and the pharmacists are getting involved as well. So to manage a patient on your own is very difficult. With the involvement of hospitals, nurses, clinics, teamwork can occur, and it can really help the patient, manage their medicines in a safe manner. Involving hospital senior leadership may be important in the future as well. So here's where we're going to talk about the pharmacist. And the pharmacist not only is a person that gives out medicines, but they can be a counselor. They can talk about drug-to-drug interactions with physicians as well as the patients, as well as drug-to-disease interactions. They can be educators. They can teach the patients about timing their medicines properly, and why certain dosages are being used. They can be a coordinator. They can track refills for their medicines. Again, they can assist with compliance. They have intimate knowledge of computerized physician order entry, because more and more prescriptions these days are being sent directly to the pharmacist via electronic health records. And they can get involved in a hospital setting, especially with the medicine reconciliation form. So community pharmacists, again, are becoming a vital part of the healthcare team. If they're not involved, they need to be involved, because they're going to help patients control their medicines in a way where safety is ensured. And it's important that clinics and doctors reach out to local pharmacists to make sure that everyone is involved with the care of all their patients. There is a coalition called the National Transitions of Care Coalition, which was founded in 2006, which is a group of individuals and organizations that have joined together to deal with problems associated with transitions of care. As we talked about earlier, transitions of care is one area where problems with medicines and adverse drug events can occur. And they've come out with a variety of white papers and statements that talk about transitions of care. And the National Transitions of Care Coalition can be found easily on the internet, and it serves consumers healthcare providers, policymakers, some information as to how this care can become better and how we can make our use of medications much safer. We're going to talk a little bit about how the quality improvement organizations are getting involved as well with patients' safety as it relates to adverse drug events. The QIOs are becoming increasingly involved with PSPCs, or Patient Safety and Clinical Pharmacy Services. And with these collaboratives, the QIOs are helping bring together pharmacists, primary care clinics, and all other providers to help ensure safety for their patients as it relates to medicines and medicine use. These teams are being formed to deliver patient care services and promote the correct use of medicines as well as the correct selection. And again, this is increasing the use of clinical pharmacy services throughout the community. And with this, the PSPC hopes to ensure safety for patients as it relates to medication use. And the benefits, with the PSPC collaborative are, there are many of them. There are statewide learning and action networks that are being put on display, at all times. There's access to tools from the PSPC to help help patients with their medicines. The ability to implement safe practices come from the PSPC, and they're able to spread success throughout the community. And right now, we're in PSPC 4.0, and the goals for PSPC 4.0, and we talked about most of these throughout the course of the presentation, but the goal is to reduce adverse drug events as well as potential adverse drug events. We want to reduce emergency department visits, hospitalizations. There's a goal towards decreasing antipsychotic use, as well as monitoring patients on certain medications such as diabetes medications and those that are taking anticoagulants such as warfarin. And I'm going to show you on a slide that hemoglobin A1Cs are being monitored and the INRs, or international normalized ratios, are being monitored as well. And with all this, high medication risks are being addressed. So multiple medications, multiple providers, inadequate medication systems are being monitored and by the PSPCs, and hopefully will decrease errors in the future. Right now we're at PSPC 4.0. August of this year, we've started PSPC 5.0, and then enrollment for PSPC 6.0 is going to start in about a year from now. And the QIOs can help with distributing best practices, helping with resources and evidence-based medicine to decrease adverse drug events. The QIOs are available to help facilities with identification of opportunities for participation in conferences, and calls, and meetings, the learning and action networks. The QIOs can help develop a medication management system and medication reconciliation system, and they can support the use of medication management educational tools for certain patients that may be at risk. And again, community networks are being formed to reduce these adverse drug events and potential adverse drug events. So where are we going in the future? Well, we're going to continue to improve our process and enhance the current processes. Communication is key between hospitals, medical associations, the QIOs, the hospital engagement networks, and all others that are involved with patient care. Safety for the patient needs to be promoted publicly, and then everyone needs to be held accountable for adverse drug events, not just the patient or the clinician giving the medicine. So as we've talked about, we're going to conclude with some basic points. The primary endpoint of this discussion and discussion of adverse drug events in general is we need to prevent them. When we prevent them, we'll decrease emergency department visits, hospital readmissions, and hopefully patients' health outcomes will improve as well. And our goal will be to improve the process between transitions, give patients better educational materials and make them more, and hopefully ensure their health and safety. And then our goal is to also enhance provider communication, which results, again, in the safer practice of medicine. And that will conclude our discussion of adverse drug events, and thank you all for taking your time to listen today.